So thanks for the organizer, thanks to my colleagues and Catherine. I will begin with Catherine. So the question we have every day from the fellow for the resident, is it still useful to perform FA on our patient? In other words, on one hand, we have the gold standard at baseline, the FA, and on the other hand, we have now the OCT-A. So does it have the potential to replace that? So it's a little bit like one versus the other, and who will win? Actually, we perform FA and ICG and/or ICG at baseline. We don't anymore use it so much for the follow-up of the patient in exudative AMD. So the question is, does it have the potential to replace FA and maybe also ICG? So in our practice, we perform in the same time OCT and OCT-A, and after that we decide if we perform or not still at baseline the FA and ICG on our patient, if it's useful. So the first question is, does it have the sensitivity to detect the lesion in type 1? Yes. In type 2, it's the same. There is a high sensitivity for OCT-A, particularly the swept source OCT-A. And again, in type 3 lesion, we can detect the CNV on our patient. So here is an example of a minimal lesion that is detected on swept source. It was a type 2 lesion with a glomerulus aspect versus FA and ICG. So we obviously think that it was not really useful to perform this invasive examination, and OCT-A gave us the answer. So 1 point for both of them. Both are useful to detect the lesion. Another point is the ability to quantify the lesion, to quantify the flow and the lesion in our patient. So we did this small software some years ago that can be applied to any device, any machine, to detect the flow and the vessel area. And the results are pretty good. So the agreement between the graders are very good for type 1, type 2, type 3 lesion. The inter-class reader and anti- and intra-reader correlation. So this is the agreement in the study we performed. So yes, we can evaluate the size of the lesion. It is reliable and it is reproducible. That is not so obvious, that was not so obvious in FA. So 1 point more for OCT-A. We are able to quantify the lesion. It's reliable, but does it reflect the reality? And to evaluate the size of a lesion, today the gold standard is not FA, but it's ICG. So we compared OCT-A versus ICG, and yes, OCT-A is at least as good as ICG, and there is no leakage, to evaluate the size of a plaque, of a lesion. There are sometimes some disagreement between both of them, but all in all, there is a very good correlation between the ICG and the OCT-A. So yes, we can evaluate and quantify the size of the lesion, and it's similar to ICG. Another point is to evaluate the degree of maturity of the lesion. Here is a lesion that was called immature lesion, that remain an immature lesion. So it's still a constant immature pattern on this patient. And on this one, we observed that the lesion turned from an immature to a mature pattern after some months of treatment. So are these lesions mature or not? Yes, probably yes. They are probably can be called immature lesion, okay, at the beginning. And some lesions are more or less mature with some degree of fibrosis on this patient. Again, some other cases with mature lesion, mature patterns and immature patterns. So OCT-A can determine a degree of maturation. This is a new notion we didn't add in the FA years, and to evaluate the degree of maturation of the vessel itself, of the flow. Some other real-life cases. Here, patients that come for annual visit with some drusen. It's just some drusen, a lot of drusen, with pigment changes in both eyes. When we performed last year and this year the SD-OCT slides, it does not change. Below, here, a small change, last year, this year. Let's see another line. Last year, this year. Yes, there is just a small cyst. Just a small cyst on this patient, and OCT-A can detect a minimal flow, but we are not sure about what we see on this en-face image. And don't forget to analyze both en-face image and the B scan on the patient. So this is the reason why we try to correlate with the FA and ICG. On the FA, it was not so obvious where was the lesion. On ICG, we can imagine, we can guess there is a small dot here. And this small dot was really correlated with both the OCT and the flow we can observe here on the OCT-A B scan. So the diagnosis is given even on this minimal lesion, and this is a name that appeared in the past months, the nascent type 2, type 3 lesion, nascent lesion. So this is also OCT-A came with a lot of new nomenclature, new names for the lesion. Another case here. It's interesting, it's amazing to see how minimal is a change on the OCT-A en face, but on OCT-A B scan, we can see a gorgeous flow here, enormous, that makes the diagnosis on the B scan. Another case with this patient with a type 2 lesion. And on the other eye, we have only some drusen that seems to be vascularized, that seems to be correlated with a small lesion, small lacy within the drusen. On FA, if we perform the FA, it was not so conclusive because there was no leakage on the right eye. On ICG, we can find again these two lesions side by side that were really correlated with what we can see. Again, there is a new name. We try to call it a vascularized drusen. It's the beginning of a type 1 lesion. Again, a small lesion, a small lacy that was diagnosed, observed, and diagnosed on OCT, and diagnosed on the OCT-A. And there is no use to perform FA or ICG on these individuals. So finally, we can say that, yes, it's already replaced the FA at baseline for our exudative AMD patient. And in routine, we are performing less and less FA or ICG to the patient. We have much more time now. I invite you, for people that want to come in Paris, the 2nd and 3rd, it's just a course for beginners. It's just for beginners. Forget it, Rick. It's just a course for the beginning people that want to learn and to try how to practice the theory and the practice for the OCT-A. This is an international course we organize in our department. Thank you, and appointment next year.